I'm Sarah Sowden. I work at Newcastle University. And for those who don't know England well, Newcastle upon Tyne is in the north of England, and it's certainly a good area to work in if you want to address health and care inequalities and achieve health equity, given that we have some of the highest rates of poverty, ill health, and early death in England. And so I'm delighted to join you all today to talk for 15 minutes around what we've been doing in some of the activity that I've been involved in England. So our roadmap for the next 15 minutes together, I'm going to just present some of the research that we've done around the evidence-based guiding principles for addressing inequalities, and then provide some examples of some activity that we've been doing, specifically the Deep End and Unfair Research programmes. I'm also very conscious that I'm going to be giving a bit of a whistle-stop tour of all of this work. So I'm going to provide all the links to where to find out more if you'd like to find out more about these programmes, because I can really only give you a snapshot today. I'd like to start with a piece of research that we published in 2022, all about, it's called actually Levelling Up Health, a practical evidence-based framework for reducing health inequalities. The aim of this piece of work was to present a practical evidence-based framework of guiding principles that help to level up health. And the choice of the word levelling up is that is something that's quite hot on the politics and political landscape at the moment in England, and something that people are talking about a lot. So that was the framing of it. What we know is the literature on inequalities remains quite imbalanced around describing the problem of inequalities rather than finding solutions. So what we did was we did a review to look at, well, what were the guiding principles that underpinned a lot of this work? There's some key components into this, which is around healthy by default and easy to use initiatives, taking long-term multi-sector action, so working together across organisational boundaries, which I know is something that you all work on very closely here in Canada. Locally designed focus, targeting disadvantaged communities. So we talked about the proportionate universalism and then the specific targeting, and then of course matching resource to need. Another overview slide that I just wanted to share with you was another piece of work that we did, and this was specifically looking at what could be done to reduce health inequalities in general practice, so in family practice medicine. And it took a realist review, an action framework approach. And again, this is a big piece of work and I haven't got time to share all of this, but I think it's really important to share these guiding principles that really came out of this work when we looked across all the literature about what were the successful interventions to intervene to address those imbalances that we all know are there in health and care. And those 5 key principles were being connected. Interventions and services should be understood, designed and delivered as connected components of coordinated action. They need to be intersectional, flexible, inclusive, and very importantly, community-centred. And if you would like to find out more about the research, the publication's there with a link, and there's also a toolkit which has many more bits to it that I've included the link to there as well. So let me just take one example of a targeted disadvantaged communities approach that we're taking here in the northeast of England. So I'd like to introduce you to the Deep End General Practice Networks. So this was a movement that started in Glasgow in Scotland over a decade ago. And it was about bringing together GPs, which is general practitioners, which I understand, I think is the term would be family health practitioners here, serving the most deprived communities to share learning and ideas and to address what is known as the inverse care law, so that we know that the distribution of resource and indeed the level and quality of care is disproportionately patterned across our population. And indeed, unfortunately, in the areas where health needs are greatest, we find that workforce pressures and the delivery of care can unfortunately be the least. And so this is something that it was really a big driver towards the inverse, addressing the inverse care law. So the idea of Deep End came from the concept of a swimming pool. Professor Graham Watt, who was a GP who worked in a very socioeconomically disadvantaged area in Scotland, talked about it being like treading water, where what you can see is that in areas of blanket deprivation, you have very, very poor health and low life expectancy, and people are drowning. Whereas those in more socioeconomically advantaged areas are doing exceptionally well, have got their head well above the water and are coping fine. And so that concept translated into the logo for Deep End. And as you'll see from that map there, there are a number of Deep End practices across the UK, but also internationally as well. And so it's become and is growing even more to be an international movement. So what is the Deep End network in the North East and North Cumbria region of England, which is where I work? So we established in 2020, and our model is very much a partnership model between family practices, public health consultants working in local government and local organisations, for example, the Office for Health Improvement and Disparities. We have a big research component to what we do. So I lead a research element to our Deep End work through the auspices of our applied research collaboration, which Newcastle is a part of, but includes all of the regional universities in the northeast of England. NHS England, which is one of our organisations that works on a regional footprint and a national footprint. And also we have more locally in the North East and North Cumbria something called the NHS Integrated Care System, which I know Will has spoken about at a previous webinar. And it is the ICS, the Integrated Care System, that provides the financing for the interventions that go on in the Deep End. And then for the research, we get research funding in to evaluate and co-design those interventions. And so the aim of the network is to bring together these family practices serving the most deprived communities to share learning and ideas, work collaboratively to change the way primary care is delivered, and create positive change for patients, practices and communities. One of the approaches we took, given the guiding principles that we know around what works to address inequalities, is that we went out to listen. So we had a view that we wanted to create a Deep End network in our area, similar to what they've done in Scotland. We thought it would be useful, but we really needed to go out there and ask people on the ground, well, is this something that you want? How could this help you? And we also needed to understand the challenges of delivering primary care in areas of severe socioeconomic deprivation, and including the experiences through the COVID-19 pandemic. So that we had a research aim around a greater understanding. And through this understanding, we wanted to co-create with these primary care practitioners and the wider network around what could we do meaningfully and impactfully to address needs and support reducing inequalities and improving health equity. And you can read more about the research at the link there. I don't have time to go into the detail of the findings from the research, but as I say, you can read it there. But I'm just going to share some of the key themes that came out of this work. It was a qualitative piece of work, and we undertook some thematic analysis. But what came out loud and clear from our work was the volume of complex patient need that presented in the Deep End. Mental health issues were a huge issue and were often very interlinked with physical health and presentations. So there was really an intermeshing of very complex need, and mental health was always there as part of that. The recruitment and retention challenges that we'd heard about from theory and practice, theory in the inverse care law, were very much borne out in practice. People felt that they were very much struggling to recruit people to work in these areas and also retain staff once they had recruited them. And there was a wider feeling that the healthcare system at large, so that wider, as Paul was saying, the wider, more upstream, midstream area, really failed to recognise the challenges. So in England, we have a lot of performance management and targets and metrics that people in family practice need to attain in order to attract extra funding. And there was a feeling that often they were penalising practices where really the target that was being set was unrealistic given the volume of complex patient need and so on and so forth. And so rather than supporting with more resource, these practices were actually having less. And I've just chosen two quotes there to show some of the challenges that people were experiencing in the Deep End, which I'll leave for you to read yourself. So what's been the impact of the research? Well, we've set up a series of webinars that are networking across all of our Deep End practices. We have 38 in our region, and it's about providing that small supportive community of practices working in the Deep End together. And it's really by the Deep End for the Deep End. And the research has led to the co-creation of pilot projects and addressing some of the key challenges that was identified through the co-design work, embedding clinical psychology in primary care, opioid deprescribing pilots, a career trailblazer fellowship scheme, and a train deep scheme to help practices in these areas become training practices, immunisation catch up, and a pilot to support the social determinants of health, because a lot of things that the people were finding people were presenting for in family care were actually things that were housing related, income related, employment related, and so it was about having those link workers there to work to take people's wider context into account and support them. I told you it was going to be whistle stop tour, so I'm going to move on from Deep End now and talk to you about the Unfair programme, which really is looking across all of the different areas about how we intervene. So Unfair research programme, again, you can click on the link to find out more, is all about how, addressing the research question, how can we reduce socioeconomic inequalities and avoidable hospital admissions? It's a 5-year programme of applied mixed methods research, and it's very much a partnership model because it's looking a lot at how systems are working together to address this. So we have a lot of partners involved from a range of organisations, including those working in policy and practice and those in an academic context. Unfair has four elements to it. So there is an evidence review, which I'm going to come on to tell you a little bit more about. Case study work. So we've done some really deep dives into some local areas, looking at what are they doing to address health inequalities on the ground, with a focus on avoidable hospitalisations, to try and share some of that, capture and share some of that learning. We have a really active public and patient involvement section, which I'd really encourage everyone. I haven't got time to show you the animation, but through that patient and public involvement work, what do the public think and feel about health inequalities, and what do they say needs to change to address them? And I'd encourage everyone to have a look at that animation. And finally, we did some quantitative data analysis looking at varying things that have happened in our local context, for example, cuts to funding of local authorities and so on and so forth, and what impact that was having on local area avoidable hospitalisation inequalities. So we did a systematic review. It's very comprehensive. We screened 23,000 records. And what was really different perhaps about this review was that, I loved Paul's slide with the sort of proximal and then the more middle range and the upstream interventions. And this review was quite unique because a lot of reviews that look at something like the outcome hospitalisations and readmissions, which is what we looked at, tend to focus on health and care, social care interventions, but we opened the intervention side of the review up so that we also included integrative interventions and then population health and cross-sectoral policy interventions as well, things like sugar taxation, seatbelt laws, all sorts of wider and more upstream things as well. A very comprehensive review, and the protocol is published there for anyone who wants to look in more detail. So the key messages was that research studies infrequently evaluate equity impact. So out of 23,000 different pieces of research that we reviewed for this, there was a handful, 30, that looked at the differential effectiveness by socioeconomic inequalities in hospitalisations and readmissions for interventions. So really a lot of the intervention research was not asking the question about what was the impact of this on inequity, and that's a really important point, because unless people start shining a spotlight, we'll not know the answers to what works. What we did find, however, is that evidence of interventions that not only reduced inequalities, but unfortunately also those that maintained and exacerbated inequalities. So the take home from that really is that well-meaning interventions do have the potential to do more harm than good. So it's really important to have an equity lens to your inquiry and co-design and evaluation as you go forward. We found effective interventions, however, across all domains of activity, which really underscores the fact that that whole systems action, not, for example, healthcare interventions alone, are required to address inequalities in healthcare outcomes, which again comes back to the importance of systems working. Finally, in terms of what were the characteristics of effective interventions, a lot of those were the ones that were upstream, so didn't require a lot of self-agency on the part of an individual to enact behaviour change. However, those interventions that were were more at an individualised level, the key there really was about being person-centred and supportive in design, which comes back to those guiding principles from Equalise around the principles that really support to enable interventions to try and aim to be more equitable. So I guess the key take home there is that patients and the public must be at the centre of everything we do. So hopefully I've provided that very brief context setting around the evidence-based guiding principles and examples of activity in England. And I've just chosen two to talk to you about that I've been involved in, which are the Deep End programme and the Unfair Research programmes. And on the next slide, which is just about to come out, and it's my last one, is where to find out more. So there's all of the web links to all of the things about our Deep End research activity, our unfair research activity, and then further and wider health and care inequalities research, including some of those frameworks and principles. Thank you once again for the time and having me here today. It's a real honour and a privilege.